We have two presentations today, and we have an international speaker, and I will be doing a case presentation after the first presentation. Now, I would like to introduce our speaker. It is my pleasure to introduce Dr. Haifa Al-Ali. Dr. Haifa is Associate Professor of Hematology and Oncology, and she is the head of Krukenberg Cancer Center at the University Hospital of Halle, Germany. Her main clinical and research interests are myeloid malignancies, particularly myeloproliferative neoplasms, AML, and MDS. And she has published research articles in top journals, including New England Journal of Medicine, Blood, and Leukemia. And Dr. Haifa, the screen is yours. You have 20 minutes. Please go ahead. Thank you.
Thank you so much. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm really honored for this invitation, and I hope that you and your families are doing fine in this rather difficult time for all of us. Today, I would like to discuss with you, based on real cases of mine, how to treat PV and ET, particularly how to identify patients who are not responding that well to hydroxyurea, and what treatment options we are having. So I just have to move this picture to go with my slides. Yeah, I just wanted to show you my disclosures. And I will start with the first case. This is a 70-year-old male. I saw him in April 2006 because of fatigue and because of a classical blood picture typical for a PV patient with a very high hematocrit. And he was JAK2 positive, as was expected. And yeah, and we know very well that looking at all the guidelines worldwide, all treatment guidelines are based on two major risk factors: age, above 60, and the presence of a previous thrombotic event. And all guidelines are actually really concentrating on how to reduce or prevent thrombotic events, because, you know, PV and ET patients generally have a good prognosis, a very long, out of good survival time of many decades. So we have to try to concentrate on how to reduce morbidity and mortality in these patients. And we know very well for patients with PV, we do phlebotomy and give the patients aspirin. I think this is well established. And then we look at the risk factors. If the patient has one of the major two risk factors just mentioned, then additionally we use hydroxyurea. And that's what I did with this patient, who for 5 years until 2011, where he was 75 years old, had phlebotomy once monthly, he had aspirin, and we gave him hydroxyurea because he's considered, according to the guidelines, NCCN or European or whatever, as being high risk just because of age. But what happened later? At 2011, the patient started to have symptoms: headache, pruritus, fatigue. The white blood cell count was rising. And now the question is, his hematocrit was doing well, but, you know, his quality of life was getting worse and worse. And the question is, how do we have practical issues to identify patients in everyday clinical practice who are really hydroxyurea resistant? Because I think hydroxyurea intolerant patients, we all are very, very, very familiar with hydroxyurea and its side effects, and we could identify these patients easily. But what about hydroxyurea resistance? And in my opinion, the modified ELN criteria that have been published a few years ago in British Journal of Hematology are quite good. Not all of them, quite good, and they could help us, you know, in assessing a patient who is losing response to hydroxyurea. I will start from below. No reduction in splenomegaly. I think we could forget this, because I think we all agree that there are only a few PV patients with really symptomatic splenomegaly. And indeed, if a patient with PV gets an increased spleen, I think the reason is not hydroxyurea resistance, but I think the reason is that this patient is transforming to post-PV myelofibrosis. So I think this is not very helpful. But I think one issue that is very important are symptoms. And this is one of the And I've done this black because this applies to our patient. He really had increasing headache, pruritus, and fatigue. Second issue are the white blood cell count. You know, this is rising. And in the ELN guidelines, we have leukocytes above 10,000, but really nobody knows what is the cutoff. Platelets, you can forget about that, and we will discuss this even with ET again, because, you know, this is only an endpoint for clinical trials, but in clinical practice, it is not really relevant. My aim is never in treating any patient with PV or ET to put the platelets below 400, because we know platelet count does not correlate with thrombosis, and treatment with hydroxyurea, reduction of platelets under hydroxyurea does not correlate with thrombotic events. So platelets are just really for clinical research. So these two factors have been identified in our patient, and the evidence comes from the work of Ruben Mesa. We know that very well, that patients with PV, although the blood counts are not that bad, could have a lot of ill-defined symptoms, mainly fatigue, which is almost present in all patients with PV. And regarding the white blood cell counts, we know from the ECLAP trial that patients with a white blood cell count above 15,000, they have almost double the risk of getting a thrombotic event compared to patients with platelets below 10. So to me personally, the white blood cell count and symptoms are two arguments to identify this patient as being hydroxyurea resistant. And again, the platelet count itself is not a risk factor for thrombosis, but you know very well it is a risk factor for bleeding if they are very, very high. So patient number 1 is hydroxyurea resistant. Patient number 2 is a younger patient. He was identified with a myocardial infarction. He had no symptoms. And doing the blood counts, again, he had a very high hematocrit and he was JAK2 mutated and was diagnosed to have PV at the time of the myocardial infarction. Again, based on the risk factors, this patient is younger than 60, but he has a thrombotic event, the myocardial infarction. So again, he's considered being high risk. We have to do cytoreduction, and usually we do it again with hydroxyurea, and this is what we did. 1 year later, the patient developed a second thrombotic event, namely a stroke. And again now, looking at the LN criteria, this patient is a patient that should be identified as being hydroxyurea resistant, because this patient developed a thrombotic event under hydroxyurea. And then we have the issue of frequent phlebotomies. This was, you know, we did phlebotomies every 3 weeks, but I think I really question this. What is frequent? You know, this depends on the age, it depends on the social circumstances, it depends on the comorbidities of the patients. And, you know, we ask always ourselves, okay, do we have really thrombotic events under treatment, under phlebotomy, under hydroxyurea? And the answer is yes. We know that despite our current treatments, every 4th patient under phlebotomy or hydroxyurea will develop at some time in the course of the disease a thrombotic event. So thrombosis in PV patients is still a relevant issue. And why is this? You know, some people argue and say, well, we are giving too little hydroxyurea to our patients and the hematocrit is not well controlled. Well, this might be true, although, you know, is it really true, you know, if the hematocrit is 46 or 47, that you have that much increase in thrombotic events? Well, we have only one cyto-PV randomized trial showing that a hematocrit below 45 with hydroxyurea is effective in reducing thrombotic events. But I think the story is not that simple, because we all have our patients. Some of them are so badly controlled with their hematocrit and still they don't get thrombotic events. And regarding the frequent phlebotomies and thrombosis, the Spanish group has showed that there is a subgroup of patients who have an aggressive kind of disease. And I think it is the biology of the disease in this subgroup of patients, so that these patients, despite hydroxyurea and phlebotomy, will get thrombotic events. But I think this is the biology of the disease. So my question is always, are we really looking at the right parameters? Are we really speaking in the right guidelines of defining high risk and low risk. And I believe that, age, for me, age, the patient argues with you. Today I am 59 years old and 364 days. Tomorrow I'm 60. Does my risk change? And I tell the patient no. And I think age, to me personally, is just a surrogate for the common cardiovascular risk factors we so often see in elderly patients. And indeed, we have a new publication, very interesting, showing, and this is no surprise, that, 2/3 of patients have hypertension. Hyperlipidemia is present in almost every third patient. And indeed, we know that the more cardiovascular risk factors we have in PV and ET patients, the more likely that they get thrombotic events, no surprise, like all other people in the population, and also the survival is shorter. And the question is, to me personally, I think the cardiovascular risk factors are very, very, very important, and much more important than just age. And the second issue, or the question I asked myself, is, do we have some other parameters, just the simple hematocrit or the white blood cell count in the blood picture we have, that might predict the probability of getting thrombotic events in our patients, or patients who will become resistant to hydroxyurea? And one such very simple parameter might be the red cell distribution width. This is an index of the heterogeneity. The higher the red cell distribution width, the more heterogeneous the red blood cell size is. And this is, a sign of hypermetabolic diabetes, hyperlipidemia, but also inflammatory reasons, the C-reactive protein, hyperfibrinogenemia. All these factors could affect the red cell distribution width, and the cardiologists have identified this simple parameter as a relevant risk factor for cardiovascular events. And indeed, again, a relatively new publication shows that the higher the red cell distribution width, about 15.6 or 17, well, there is not yet a clear cutoff, the more likely that you can anticipate cardiovascular and thrombotic events, a reduced survival in patients with PV and ET. So I think we need to have more data, but I think it is worthwhile looking additionally to the hematocrit, the white blood cell count, to the red cell distribution width. Okay, now we have two resistant patients. What do the guidelines tell us? Second line is either a clinical trial, but we have Ruxolitinib and interferon. These are two approved drugs as second-line treatment. Where does the evidence come for interferon? In summer, I think it is also approved in Saudi Arabia. Ropec interferon, a special formulation of pegylated interferon, has been approved in Europe and the United States for the treatment of first line and second line for the treatment of PV patients based on the data of the PROUD PV trial. Comparing Ropec interferon, we all know interferon, and Ropec interferon has only one major difference, that you don't have to give it that frequently. You give it initially every 2 weeks and then once monthly, but otherwise it is an interferon. And hematological responses are comparable to that what we know under hydroxyurea, but we know that there are a lot of molecular remissions starting to appear in many patients with PV after 2 years or 3 years under treatment. To be honest, we still don't know what the meaning of this allele burden reduction means for PV patients in terms of survival, in terms of thrombotic events. But this is, I think, a very, very interesting observation, and it's particularly for younger patients, the issues of pregnancy, even lactation, that is quite possible with this treatment. The second option we are having is Ruxolitinib, and the approval came based on the randomized response trial. The primary endpoint was, the reduction in spleen, but I told you the spleen doesn't play a big role in PV. The hematocrit control, okay, but I think a very strong argument for the use of Ruxolitinib in a subgroup of patients with PV are, the symptoms, especially pruritus, fatigue. It is really very, very effective if these symptoms are present. So how did we manage our patients? And, looking at efficacy, we should never forget safety. And, hydroxyurea is well known. Interferon is also known, and I think ruxolitinib too. But I just want to draw your attention to the non-melanoma skin cancer, which is very, very, very frequently seen in patients with PV and ET. And it is not a question of treatment. This is inherent to the disease itself. We see it under hydroxyurea, and we do see it quite often in patients with a previous history of non-melanoma skin cancer treated with ruxolitinib. So I think this is an important issue, and we in Germany send our patients to the dermatologist every 2 years, and you will be surprised at how often there are strange skin lesions discovered by the dermatologist. So back to the patients. Patient number 1 was an elderly patient. Main problem was symptoms. So I decided to start him on ruxolitinib, and indeed he is doing very well for now many years, and normalized the counts, but most importantly, the improvement in his symptoms. For patient 2, because of the young age, because of the hope of reducing the JAK allele burden and maybe to modify the risk of thrombosis, although we don't have evidence. So I started this patient on Ropec interferon 100 microgram every 2 weeks, and then once every month. The patient was doing well. And indeed, on the bottom line, for both ruxolitinib or interferon, we don't really have strong evidence that with this treatment we could reduce thrombotic events, although some long-term data of the response trial may suggest this, but the trial was not powered to prove this. So the issue of thrombosis is still a quite complicated issue in PV. Just a few words to my ET patient. This is a very young lady. She had very, very severe symptoms. Nobody believed her. This was a nurse. And she had such severe, chills, fatigue, headache. She had 4 hospital admissions. Everybody thought she is psychologically, depression, and she had even social problems with her husband and kids. And when you look at her blood counts, apart from a slightly elevated platelet count, she didn't have any other abnormality, and she was calreticulin mutated, which is the case in about 15% of ET patients. And looking at the guidelines, she is a very low risk patient. She has no thrombosis, she's young, and she's non-JAK mutated. She doesn't have a cardiovascular risk factor, so observation. The question is observation adequate for this symptom? And I like these guidelines recently published by Tefri and Tiziano Barbui, because you see the emphasis on the cardiovascular risk factors, the yellow bottom going along all risk groups. And interestingly, one point here, you do not have to start with hydroxyurea if the patient becomes 60. So you look at the cardiovascular risk factors, and from where does this evidence come? From the recently published paper where, patients between 40 and 59 years were randomized between hydroxyurea plus aspirin or aspirin alone. And after a follow-up of 6 years, there was no benefit, no reduction in thrombotic events in ET patients if we added hydroxyurea. This means that a patient who started the trial being 59 for 6 years follow-up, he was then 65, and as we have seen no increased risk of thrombotic events, here the guidelines tell us it is optional if the patient doesn't have a cardiovascular risk factor and only age above 60, and that's why I like it very, very much. So the question is, in this lady, is she psychologically ill, or does she really have ET-related symptoms? And again, thanks to the work of Ruben Mesa, we have learned that patients with ET, even very low risk, might have severe symptoms. And indeed, our patient belongs to cluster 3. These are patients with many symptoms. Many of them are low risk, and they almost have no lab abnormality. And indeed, this lady belongs to cluster 3. So what could we give these patients? Unfortunately, for ET, we do not have that many randomized trials. There is only 2 trials, actually, anagrelide versus hydroxyurea for high-risk patients. And again, after a follow-up of 5 years, there was no difference between anagrelide and hydroxyurea regarding thrombosis. Issues of tolerability were similar. And, with anagrelide, we always have this story of promoting fibrotic and earlier AML transformation. But, the older trials, the pre-fibrotic MF and ET were not really differentiated. So there is still a big question mark, and especially in younger people with extreme thrombocytosis and bleeding, I like anagrelide very much. In elderly, I am very cautious and do not use it that often. And the second randomized trial we have is Ruxolitinib versus best available therapy in ET patients as second line. And on the bottom line, I can tell you, Ruxolitinib is not that effective in patients with ET. And in Germany, we have a trial going on, but the results are not very encouraging. And again, there was no benefit to Ruxolitinib compared to best available therapy. Just a few words, don't forget busulfan in very old people. Low dose busulfan, although the number of patients are small, could be quite effective in very elderly patients to improve symptoms, to improve counts. And the dose could be then as a maintenance 2 milligram per week or even 2 milligram per month, depending on the lab parameters. But to me, the best drug for especially younger patients with ET who need treatment is interferon alpha. Although we don't have randomized trials, we know the adverse events, but still, it is a good drug. Although it is not approved, but we use it even without asking our insurances. So back to these people. I always start aspirin if symptoms are present because, many of the symptoms are related to microcirculatory disturbances. And indeed, in many patients, you just give them aspirin 100 milligram, and in many of them, the symptoms disappear completely. So aspirin is very effective sometimes. And we have to just remember, if the platelets go above 1 million, please just screen for ristocytine cofactor activity. If it is below 20%, then please stop aspirin and start cytoreduction, because we know that the acquired von Willebrand disease is not seldomly seen in these patients, and this accounts for many bleeding events. And again, please, as I said in PV, don't look at the platelet count as an indicator for treatment unless we have an acquired von Willebrand. So I gave this lady aspirin, but the symptoms did not disappear completely, so I started her with pegylated interferon. And 2 weeks later, this lady jumped at me and hugged me because all the symptoms disappeared and she was doing really well, and she is now fully working. So just one word, should I change my approach in MPN patient general in the COVID era? I tell you the answer is no. I think it is always a risk-benefit assessment we have to do. Maybe one point that we have to remember is the high incidence of thrombotic events in PV, ET, and MF patients. And if they get a COVID-19 infection, the thrombotic risk will increase. So it might be wise to start low molecular weight heparin in these patients if they get a COVID-19 infection. And indeed, the Italians have published a very nice work where they asked their doctors, would you start cytoreduction with hydroxyurea or interferon alpha if your patient is having COVID-19? You see, the majority of physicians, the blue bar, said yes, we will start. The same is true for Ruxolitinib. And would you reduce the dose of Ruxolitinib if your patient gets COVID-19? No, the majority said no, and I agree fully. If they have a moderate COVID-19 infection, I would reduce the dose, but I would not stop, because you might aggravate the cytokine storm that is often seen in patients with COVID-19 infections. And with this, I come to my conclusion. I think PV and ET are more than just a simple hematocrit and platelets. And we know the job as physicians is to put a lot of puzzles together: the patient, the disease. As I said, please look at the cardiovascular risk factors as the red cell distribution width in the blood picture. And we always have, when we choose treatments, to weigh between efficacy and safety to ensure an optimal outcome with a good quality of life in chronic diseases. And with this, I would like to thank you very much, and I'm more than happy to take questions. Thank you very much.
Thank you very much, Dr. Haifa. Excellent presentation and really very thought-provoking. We will have the question and answer session at the end of the second presentation. So just bear with me till that time. Just an announcement for the audience. Near the end of my presentation, the question and answer mode will be activated, and you will see it on the right side of the screen. And then you can type your questions and ask your questions. So I will start. I have a case presentation. So this patient presented in March 2010 to the urology clinic. He was 74-year-old at that time. His symptoms were burning micturition, frequency, and urgency. And he had recurrence of these urinary symptoms despite multiple antibiotic courses. He had a 1-month history of dizziness and headaches, which were frontal and occipital in origin, but there were no visual disturbances, there was no tinnitus, and there were no other CNS symptoms. He had mild but generalized itching. He had a past history of hypertension for a few years, for which he was taking amlodipine. His examination showed that his vitals were normal, and rest of the systemic examination was also normal. Particularly, he had no splenomegaly. So he underwent a cystoscopy by the urology team, which came out to be normal, and no pathology was found. Now, his lab investigation showed that his CBC was abnormal. He had a very high hemoglobin of 21.5 grams per deciliter and a high hematocrit of 66.2%. His white cell count and platelets were normal, while he had a slightly raised urea and creatinine. So on the basis of his urinary presentation, a chronic tubulointerstitial nephritis secondary to NSAID use was suspected. So he was admitted and a hematology consultation was made. Hematology saw him, and because of his high hemoglobin and hematocrit, polycythemia, possibly polycythemia vera was suspected. So a JAK2 mutation testing was requested along with serum EPO, and a bone marrow biopsy was also considered. And he was started on initial phlebotomies. Because of his older age, we started with 300 ml per day. So he was also started on low dose aspirin. He completed 5 sessions of phlebotomies, and his hemoglobin dropped to 17.5 from an initial hemoglobin of 21.5, and hematocrit came down to 52% from 66.2% initially. So the JAK2 mutation came to be positive, and bone marrow biopsy was done, which I will show in a minute. So he was diagnosed to have polycythemia vera, and he was started on hydroxyurea 500 milligrams per day. This is the bone marrow biopsy in polycythemia vera patient, and as you can see, this is the aspirate, and this is the tree-fine biopsy. And as you can see, that this patient has increased cellularity. It's a hypercellular marrow with panmyelosis, which is typical of polycythemia vera. So his follow-up in August 2010 in the clinic, he did not have any complaints. His hemoglobin was still high, along with a hematocrit of 54.7, while white cell count was normal and platelets were slightly high. So he underwent more phlebotomies, and the hydroxyurea dose was increased to 1 gram per day. He was again seen in April 2011. He had no issues, although hemoglobin and hematocrit was still high, but better than before, while the white cell count this time was a bit high, 12.1, and the platelet count was normal. So he underwent further phlebotomies, and the hydroxyurea dose was increased to 1,500 milligrams, alternating with 1 gram on daily basis. Now, just to give a perspective, this patient actually lives outside Riyadh, about 300 kilometers. So this patient was not very regular in follow-up. So at times, his son would attend and the clinic just to renew the medicine, sometime even without a blood count. So these are some of the challenges we face from time to time, and we may have to treat the patient even without the full investigations and full workup. So he was again seen in December 2011. He complained of significant pruritus. His hemoglobin and hematocrit was reasonable. Hematocrit was 46%, while the white cell count was again 11.1, and platelet count was higher this time, 750. So he was continued on the same dose of hydroxyurea, and antihistamines were added for his pruritus. He was again seen in January 2013, and this time he presented to ER. He had a severe abdominal pain and constipation. He underwent exploratory laparotomy for a perforated duodenum. So white cell count and platelets were quite high this time, and they were actually considered to be reactive because of his acute illness as well as surgery he underwent. So he had a perforated duodenum, which was repaired. So during the post-op period, this patient started to have visual hallucinations. So if such a patient has a CNS symptoms, obviously you would consider either bleeding or thrombosis. And thrombosis is one of the main complications in patients with polycythemia vera. So a CT scan was requested. And on the left side, you can see the CT scan. It did not show any bleeding, although there was an incidental finding of a hemangioma, which is shown here, if you can see the pointer, which was considered to be of no significance. And he underwent an MRI as well to rule out any thrombosis. And actually, there was no thrombosis. So his condition improved. And he was discharged on hydroxyurea 500 milligrams daily, which was actually stopped during his acute illness. And we plan to increase the dose slowly. In April 2015, he again presented to the emergency with complaint of severe upper abdominal pain, which was radiating to the back. It was not related to the food, and he had normal levels of serum lipase and amylase, rule out the acute pancreatitis. His white cell count was highish on 18.3, while hemoglobin and hematocrit was actually the lowest since he was initially diagnosed, with a hematocrit of 40%. Platelet count was 900, and MCV was low, with a value of 69.3. So he underwent upper GI endoscopy, and it showed an enteral gastritis and 2 small clean-based duodenal ulcers. And a biopsy was taken, which showed mild active gastritis with H. pylori, which was positive. So he was initiated on proton pump inhibitors. He received H. pylori eradication therapy, and aspirin was replaced with dipyridamole. This was on the request of the surgeon. And hydroxyurea was increased to 1 gram per day. In November 2014, he again presented with the lower abdominal pain and dysuria. He had severe itching this time all over his body, and hemoglobin was quite low. It had dropped to 9.9 with a normal MCV, while the white cell count and platelets were normal. His serum creatinine was 125, which was actually his baseline, and it has been stable over the years at this level. A urine microscopy showed increased white cells and good number of RBCs. So I just have a quiz for you to keep your interest. So what do you think are the diagnostic possibilities for this patient for the low hemoglobin? Do you think this could be bone marrow suppression due to hydroxyurea? Do you think this could be iron deficiency anemia due to GI bleeding? This could be myelosuppression due to infection? Or do you think he may be transforming to myelofibrosis? Or you think if this could be a combination of the above? So when a patient with polycythemia vera presents with a low hemoglobin, you have to consider all these options. So I will go through one by one. So he had a UTI, which was treated with antibiotics. There was no clinical evidence of GI bleeding. His spleen was not palpable, and peripheral blood film did not show any features of myelofibrosis. So that made myelofibrosis transformation less likely, although it does not rule out. A bone marrow biopsy was considered, but it was refused by the patient. So hydroxyurea was stopped temporarily. He received the short course of iron supplements because he was thought to have some iron deficiency. And he was started hydroxyzine, which is an antihistamine considered to be good for itching, at a dose of 50 milligrams per day, which was later on increased to 100 milligrams per day. There was mild improvement, but he continued to have disturbance of his daily life with the sleep, which was disturbed, and he was not able to sleep well almost every night. So what will you do next for pruritus? He's on hydroxyurea, and he's also receiving antihistamines, and it is not controlled. So would you consider an alternative antihistamine? Would you consider alpha interferon? Would you consider busulfan, which was mentioned by Dr. Haifa? We used to use a lot in the past when we did not have the new treatments, but now rarely used. Or would you consider ruxolitinib? Because we don't have the option of voting. So if your answer was either interferon alpha or ruxolitinib, I think both of these answers are correct. So he was started on ruxolitinib 20 milligrams per day in a dose of 10 milligrams twice a day. His pruritus dramatically improved, and in March 2016, he was seen again. There were no new complaints, and to particular note, he had no pruritus at all. So he was continued on the same dose of ruxolitinib. His hemoglobin was risen to 12.9 with a hematocrit of around 37. white cell count and platelets were within the normal range. So his last follow-up, which was a few months ago, he was well. He had no complaints. He's now 84 years old, and he's being followed for 10 years. And this is his last CBC. His white cells, platelets, and hematocrit, they were all normal, and hematocrit was very reasonable at a 42.2. He's continuing on Ruxolitinib 20 milligrams per day for these years with no recurrence of the pruritus, as well as very well controlled hemoglobin and hematocrit. So in summary, this is an elderly gentleman with polycythemia vera who had multiple complications associated with polycythemia vera. He had severe pruritus, which was managed with Ruxolitinib with excellent response and long-term control of hematocrit. So I have few slides regarding his complications and problems. So pruritus and polycythemia vera can be intractable, and it is typically aquagenic and can represent a disabling condition in some patients with myeloproliferative disorders. But particularly, it's more common with polycythemia vera. The pathogenesis is unknown, although JAK2 mutation-induced constitutive activation and agonist hypersensitivity in basophils of these patients have been demonstrated, and which may be associated with the pathogenesis of this complication. The vast majority of polycythemia vera patients, they experience a lot of symptoms, and this can actually disable them, and this can cause a lot of problems with their daily life and reduce quality of life. Now, of particular note, these symptoms could be related to their polycythemia vera. This could be the constitutional symptoms like weight loss, fever, and night sweats. These could be related to splenomegaly with abdominal symptoms, with early satiety, abdominal pain, etc. These could be other symptoms like pruritus, like fatigue, and like insomnia, a lot of other symptoms. Of particular note, these symptoms can occur independently of blood values or disease duration and myelosuppressive treatment. So in spite of the good myelosuppressive treatment, these symptoms can be present and can be quite intractable. Now, pruritus in polycythemia vera is present in around 2/3 of the patient, and this is one of the most common symptoms along with severe fatigue in these patients. Pruritus interferes with the daily activities and has been associated with suicidal ideation because it can cause so much crippling of the daily life. So these patients can have a real poor quality of life because of pruritus and the other symptoms. So how should the management of pruritus be carried out? Now, initial treatment is usually antihistamine such as cyproheptadine or other antihistamine, whichever is available. It may be of some benefit in some patients, although many patients will continue to have symptoms. If this is not successful, interferon alpha and more recently the PEG interferon in a dose of 3 times per week in case of the older preparation of interferon, which we don't use really these days, or pegylated interferon on weekly basis can actually be effective in many of these patients. The other treatment options include selective serotonin uptake inhibitors like paroxetine, and more recently, JAK2 inhibitors and mTOR inhibitors have shown impressive activity in this condition, as I've shown you in this case, and as Dr. Haifa showed earlier. Now, I just want to say a few words because there is some time regarding the gastroduodenal lesions in patients with polycythemia vera. If you see the old literature, it is actually quite frequently mentioned that these patients may have these lesions in many cases. Although more recently, we don't, they seem to be much, the concern about this problem. And I searched the literature and did not find much in the recent literature. This is one of the studies which was published many years ago in British Journal of Hematology. And just to give a summary, although it's a small study, but they compared polycythemia vera patient with controls, and polycythemia vera patient showed a significantly higher frequency of erosions, ulcers, H. pylori positivity, which was in 83% of the cases, and anti-KAG positive antibody in those patients. So these patients has much higher incidence of gastroduodenal lesions. So both PV and H. pylori infection were independent risk factors for gastroduodenal lesions. The underlying pathogenetic mechanism responsible for gastroduodenal lesions in PV possibly involves blood mucosal flow and trophism, which can disrupt the mucosa. And of course, the treatment with aspirin may also cause the aggravation of this problem. The higher susceptibility of H. pylori infection and the high frequency of asymptomatic gastroduodenal lesions in PV patients suggests that a surveillance of these patients should be carried out, and there should be a low threshold in suspecting this problem. And as I showed in case of my patient, this patient really had multiple lesions. He has gastric ulcers, and he also had a perforation of the duodenum, which it is not a common problem these days, but it can happen in some patients. So with that, I will stop. Thank you very much for your attention. And now we will start the question and answer session. And before that, I just want to thank our sponsors, Novartis and Takeda. And they are doing a good job by supporting these webinars. And I think this is a great activity. And I would also like to thank the SSBMT for a great effort in doing these webinars. And they are really, very interesting, very informative, and keeping us updated in these difficult times when the physical meetings cannot happen. So I just need to see. So, Talat, is this the question and answer has been okay? So I will just check the list. So before I go to questions, I would just like to ask Dr. Haifa. I have a very young patient. He's 29-year-old with polycythemia vera, and he is not very regular. He has no thrombosis history. But he's difficult to control with phlebotomies. So what will be your choice of treatment? Would you avoid hydroxyurea in such a young patient? I'm not sure he will agree with the interferon injections,
Right.
Although I suppose interferon would be a good option. So what would you do?
For me, it is always interferon in these younger patients because, hydroxyurea, we know there is always the issue of leukogenicity of this drug, and it might accelerate transformation to AML. We have very good evidence that giving patients hydroxyurea for the first 10 years, we don't accelerate the transformation to AML. But after the 10 or 15 years, there is no evidence, and we know the natural history of polycythemia vera. So in a patient with 49, the life expectancy, I always try to give interferon in these patients. Regular interferon is difficult, but I don't know, is ROPEC interferon available?
It's not available in our institution, but I don't know the other institution. But we have PEG interferon.
Yeah, but PEG interferon, you don't need to give it weekly. In the beginning, I give it weekly, and you need only regularly 45 microgram in the majority of patients. And indeed, I could, in almost all patients, increase the interval so that the patients with pegylated, I give them every 2 weeks 45 microgram, and you get in most of the patients really beautiful results. So this is always something, to try to convince the patient instead of taking it weekly, you could try to do maybe 90 every 2 weeks. But for that so younger patients, I am really very reluctant to use hydroxyurea.
Would you consider ruxolitinib if the patient does not agree to take interferon?
I would, yeah, sure. But the problem is the major hematocrit control. Yeah, you could. But ruxolitinib is for me, as I showed very clearly, and you showed beautifully, it is a very, very good drug if patients have a lot of symptoms, because the patient has to take the drug twice daily. And if the patient is feeling well, the question is, how will compliance be? Sure, it is. I would try first in this particular patient with interferon alpha.
I will, because he's 29 years old. He's very young. This is the youngest patient with polycythemia vera I have. So I will sit with him and I will see,
Yeah,
but my feeling is he may not agree for interferon.
Yes, but you can argue with him long-term results. With ruxolitinib, we have only a follow-up of 5 or 6 years. And again, in such young people, you always ask yourself, what happens after 6, 7 years, after 10 years? And the second issue, you could maybe, try to catch him. You have the hope of reducing the JAK allele burden. Although today we don't know what the impact is on the long term. But this is, a hope of patients that they might one day, like in CML, and, the tyrosine kinase inhibitors, that they might get a treatment-free remission. So I would really use all the arguments in the world to try to put these patients on interferon.
Excellent. So we have another question from Dr. Ahmed Alaskar. So why do you think RDW would be a risk factor for cardiovascular disease in PV as well as ET?
Because this red cell distribution width is an impression of cardiovascular risk factors, as I said, but it is also increased if you have inflammatory issues. An elevated C-reactive protein, elevated fibrinogen, for example, interleukins. All of these could increase the red cell distribution width. So the red cell distribution width might be, a mirror reflecting both cardiovascular risk factors and inflammation in these patients. I think it is a very good, as I said, we need data. This is very new. And indeed now, Verstovsky from MD Anderson, they are having a big project with the intelligence, computer-based, to try to, and the red cell distribution width came out as a very relevant factor in predicting hydroxyurea resistance and in predicting thrombosis within a short time. So I really believe that, because, as I said, it is a mirror of inflammatory and cardiovascular risk factors.
Excellent. So we have another question. Do you treat ET, which is JAK2 positive, same as the ET, which is Carl reticulin positive? So any consideration apart from JAK positive, and whether these patients have higher VTE risk?
This is a very good question. It is, we know that ET that are JAK2 mutated have a higher risk of thrombotic events. But, for the whole cohort of ET patients with a very long history, this makes a very small difference. Nevertheless, I don't treat them differently. My answer is I don't treat them differently, but we know very well that calreticulin mutated patients, like my patient, are more likely to respond better to interferon alpha. So I don't treat them differently. Well, although the paper I showed you from Chevry and Barbui, they give JAK mutated ET patients aspirin, which is not given if they are low risk. But I think this is too complicated. Don't make the difference, no.
Okay, great. So we have another question. How would you treat patient with the thrombotic history and JAK2 positive but normal CBC?
This is an excellent question. Classical example are all these young females we have with Budd-Chiari, with splanchnic vein thrombosis. These patients get their thrombotic events, they are JAK2 mutated and have a completely normal blood picture. And that's why I'm always arguing that it is not a simple issue of hematocrit and platelets, because they get thrombotic and really life-threatening thrombotic events with completely normal CBCs. And I treat these patients, because per definition, they are high risk, and they are high risk, and I try. And the majority of these patients are younger people. We give them anticoagulation for life. And the second is I always give these patients with interferon alpha. I have no evidence that giving interferon alpha will affect or reduce the risk of a second thrombotic event, but the clinical experience shows that it is working very, very nice. And we had patients with Budd-Chiari very close to liver transplantation, and with interferon alpha and anticoagulation, they are doing really perfectly well.
I think this is another question, but part of the same question. Would you consider cytoreduction, and how will you follow? This is for the same patient we discussed.
Exactly. How could I follow these patients? Nobody knows. They have a normal blood count. The patients I have now for years, all of them, I have really a big army of these young ladies, and I never had a second thrombotic event. So I believe that we are doing right. But as I told you, we don't have evidence, because exactly what should we measure? We are measuring the well-being, that we are following up these ladies. Some of them are getting JAK2 negative. They are having complete molecular remissions. But nobody knows, because, the theory is that the JAK2 mutation in the endothelial blood vessel cells and the slows flow of blood might be contributory factors for local thrombotic events in these very atypical sites. But again, I have no proof. I don't treat them with hydroxyurea because, you know, hydroxyurea does not really affect anything and they have normal counts. So I give these younger patients all interferon alpha.
So if the hematocrit is at the higher level, but within normal range, like within the late, you know, the 44 or 43, would you consider lowering it further, or would you just keep it and treat the thrombosis?
I keep it because, you know, you have heard from my talk, I am not that strong believer in this absolute 45% cut. I give you an example. Bogota, the capital of Colombia, it is 2,600 meter above the feet, and I really had a lot of research to see, you know, every male patient living in Bogota, and this is a city with 8 million people, is having per definition PV. The lowest hematocrit is 48%. And the thrombotic risk is not increased at all. So it is not a simple hematocrit issue. As I told you, it is inflammation, it is the JAK2, and the TET2 mutations in some of these patients, the inflammation associated with the high white blood cell count. And that's why, no, I don't lower below 45. I try to keep the patients because, you know, patients can sue me if you have to have randomized trials to prove, because the cyto-PV trial is a very old trial, you know, it is now more than 20 years ago, and the initial primary endpoint was actually 50%, and then later it was lowered down to 45. And I always ask myself, look at our old COPD patients, right? We have so high hematocrits, and we don't have that many thrombotic events. And that's why I try to keep patients at 45, and not, you know, because if I do a lot of cytoreduction and to reduce the hematocrit by phlebotomy, we will induce iron deficiency, the fatigue, and, you know, we get the patients into a vicious circle. I don't do this.
Okay, so we have another question from Dr. Hafiz Malhan. How frequent should you repeat JAK2 tests in positive and negative cases? I suppose probably he means whether you would do the allele burden and whether you follow it with the allele burden.
Yes, we do that indeed, just to learn. But in normal clinical practice, it would be enough to have it once to prove that the patient is JAK2 mutated or not. And then it is enough. The allele burden, we do it regularly, but, you know, until now, we don't have any therapeutic consequences from the allele burden.
So if you put a patient on interferon, would you consider, you know, the doing their allele burden, because some of these patients may become negative?
Yes, we are doing this regularly, and indeed, around 1/3 of the patients treated with interferon after 2 to 3 years become JAK allele burden negative.
Excellent.
But as I told you, I don't know what to do with this information. Patients come to you and tell you, would you stop my treatment? I tell them, no, we have no evidence. We needed 15 years for CML to do treatment-free remission. And until now, we don't have the clear evidence that stopping treatment, when they become JAK2, you know, negative, what will happen? We don't know. So I don't stop treatment.
So in routine clinical practice, you do not recommend doing the allele burden or repeating the JAK2 levels?
You don't have to do it, but, you know, it is very interesting because we are all in the process of learning. So if you have the facility, I think it is quite interesting to do it once yearly. I don't do it more than once every year.
Excellent. So do you have a cutoff for the age to use hydroxyurea versus interferon?
Yes, a very good question. Interferon in elderly, the tolerability is not that good, but the definition of elderly, usually after the age of 65, I do not use interferon as first-line treatment because I know that the tolerability, you get a lot of side effects, and, you know, to stop it and so on. And for hydroxyurea, I said I try to avoid hydroxyurea in patients below 55 if possible, because I always think about the life expectancy and stuff like that.
Excellent. So we have another question from Dr. Ahmed Alaskar. Would you consider higher doses of aspirin in certain situations?
This is again a very, very good question. But, you know, and even some recommendations do say you could use twice daily. There are some in vitro data showing that some patients are not adequately having an effect with the once daily, and but usually we don't have evidence. And we have discussed this issue in detail actually 3 days ago with our cardiologist. And even the cardiologists, in their very vast experience, do not suggest using aspirin twice daily because there is no clinical evidence that using it twice daily will reduce the risk of another thrombotic event.
But some patient may have aspirin resistance, right?
Absolutely, absolutely. And we have in vitro tests, you can prove that very well in vitro. And maybe in these patients you can consider, but you have to be very careful because of the issue of bleeding in our patients. And sometimes, they have really major bleeding. So if I have a younger patient with aspirin and then he gets a stroke, I think I would put this patient on twice daily. But I would do this on a very limited individual base and weighing between the risk of bleeding and risk of thrombosis. As I told you, we discussed this issue a few days ago with our cardiologists, and they did not support this idea.
Excellent. So we have another question from Dr. Najat. Would you treat iron deficiency in PV patients if they are symptomatic of IDA?
This is very good question. This is we do sometimes, we do. And indeed, for me, a criteria to stop phlebotomy is, symptoms of iron deficiency. And usually I follow the MCV, you see, I am somebody who likes a simple test. When I see an MCV dropping down below 70, 65, I usually patients start, and this is for me an indication to rethink phlebotomy alone. And according to the age of the patient, I might add hydroxyurea or interferon alpha.
But one has to be careful, giving a small dose for a short period, so not to
right.
Get the very high hematocrit levels.
Right. So we give them iron for a very short time, for 2 or 3 weeks, just to try to increase the MCV. But we should be very careful because both we have the rebound, right, of the hematocrit.
Excellent. So we have another question from Dr. Ahmed Al-Shumar. Would you treat PV patient whose age is older than 60 years, but without any history of thrombosis? So would you treat them with cytoreductive therapy?
According to the guidelines, I must. But as I told you, I am very, very critical. I discuss this issue with the patients. And if it is only 60 without cardiovascular disease and nothing, I don't usually go automatically to cytoreduction. And we have actually finished a protocol very recently where we included 245 patients from real world data. And age, as I showed you, age per se alone is not a predictor of thrombotic events. And actually, and as expected, and as I showed you in the paper, it was the cardiovascular risk factors that was a predictor. And interestingly, the majority of thrombotic events in our cohort occurred prior, in the first 3 years after the diagnosis. You almost had nothing about later than, and the main issue, and this is something we have to discuss, thrombotic events in PV and ET patients, 2/3 of them happened before we hematologists could do anything. So I always question when I say 30% incidence of thrombosis, this is right, but 2/3 of these 30% occur before we make the diagnosis. And however good we are, we will never be able to prevent these 2/3 thrombotic events. And I think this is a very important issue, and I always ask myself, what is the endpoint of, new drugs and clinical trials? Because the incidence of thrombotic events after the diagnosis, I think because we are so good in the treatment, especially aspirin, I think is a very, very good issue, is very low in these patients.
Excellent. So we have 1 minute, so I will ask you a very quick question. So if a patient, a newly diagnosed patient, presents with the venous thrombosis and patient is started on anticoagulation, would you continue them on lifelong
Yes.
or would you later on replace with aspirin? The reason, because I had an argument with one of the international, the expert, and he said the myeloproliferation is very high in the beginning, but when it is controlled after a few months or a year or so, you may be able to stop anticoagulation and just put them on aspirin, because this patient is not the same as the patient who presented initially with a very high myeloproliferation.
Correct, correct. This is something you can consider, and indeed, you know what I told you, even in our cohort, the first 3 years, the thrombotic events occurred in the first 3 years. So the patient is very stable and, you know, no risk and everything is controlled. You might consider switching the patient back to aspirin. But again, this should be done on an individual basis because the evidence is not strong.
Right. Excellent. Thank you very much. I think the time is over now, so we have to stop. Dr. Haifa, thank you very much for your excellent presentation and very, you know, the informative answers to all these questions. We really appreciate. And thank you very much again. And I would also like to thank our sponsor today, Novartis. They are doing a great job by sponsoring these educational meetings and webinars. And in the end, all the audience who participated in this webinar and asked these nice questions, thank you very much. And finally, I would like to announce that we have the next SSBMT webinar coming. It is on multiple myeloma, and we have international speaker, Dr. Muhammad Mufti. He will talk about CAR-T and bispecific in multiple myeloma. And second speaker would be Majid Al-Ahmadi, and he will talk about how I treat IMID refractory multiple myeloma. And this is going to be on coming Wednesday, 2nd of December, from 9 to 10 a.m. at 9 to 10 p.m. Sorry, and this is because of the forthcoming ASH meeting. So the day has been changed from Saturday to Wednesday. So thank you very much again, and have a nice evening.
Thank you. Goodbye.
Thank you. Bye bye.